150,000 and more than 250,000 people that the East African and life were lost. And as I've said, now we have now the newly and data for the 2022 that, and now the estimate of this is 43,000 people might have died in 2022 due to droughts and climatical changes in the country. And this is, and according to the research, is also on top of the iceberg. And as you can see here, the patterns you can see from 1992 to 2022, and we have a repetitive, and it is getting worse and worse as years goes by. And this is evident that climatical change is getting and is more frequent than before. And you can see now the timeline between 1997 to 2006, and now as we come towards 2022, it is getting more frequent, and this is evident and in terms of of the impact and the displacement it is causing. And the IPC analysis that has been conducted by Somalia IPC Technical Working Group and reviewed by the IPC Famine Reviews Committee also creates indication that famines are occurring now in 2022. And I have said that the report now we have just received that was published is already showing the figures and numbers that 43,000. And next slide. And I wanted not only, and we cannot, and do a presentation in 2022, 2021, 20 without mentioning COVID-19. COVID-19 has been one of the public health disasters in the century, and the pandemic has really exposed countries that had very stronger health systems, and really has damaged and pushed to the limit to the countries that were in fragile states like Somalia. And the risk reversal of the most fragile and vulnerable settings have been really been tested. And one of the things, and this picture is showing, is that oxygen, supply of oxygen has become a medicinal need, and it became very vital to have oxygen supply and to treat the COVID-19 pandemic. And next slide. Well, what we can see is I want just to share with you, and this the primary healthcare 20% the COVID effect of has been the COVID and disruption of the essential health services, and 20% reduction in life-saving vaccination coverage. And one of the things is that, and I can just want to mention here, is that, and we had a challenge. We know very well when Somalia is an endemic malaria country, and when COVID was there, it was, the messages were given was like, if you have temperature and fever, and isolate yourself and stay at home, while somebody who has malaria can have also fever, and these mixed messages. So there was disruption of the symptomic of diseases, and it really created and disrupted the routine vaccinations, whereby we can see the infectious diseases and care has reduced, and 13% increase in childhood mortality, and because of the COVID-19 impact, and all the routine immunizations and focus on other infectious diseases have really been disrupted, and this is mainly due to the attention and the disruption and brought by COVID-19. Next. And response to COVID-19, and despite the pandemic overwhelming already, and the health system of the Somalia was already fragile and vulnerable to start with, but together with our partners, we were really able to respond to the COVID-19. I was lucky enough to be the incident manager of 3 waves of COVID-19, through the first wave and the second wave and again the third wave. And all we know that the COVID-19 was changing variances, and the first starting from this, the ones that started with the naming of the country, the South Africa, the Indian version, again when the world decided to change the names to Omicron. I've been the incident manager, and we have really tried to show, and in some way we say that although a disruption has been done, there was some blessing that we were able to do essential diagnosis of PCR in the country, and we were able to train laboratory technicians, and also to do not only to doing the PCR, and this is the first time that the PCR testing was conducted in the country, and we also managed at later stage to do the genomic sequencings of the variant of the COVID-19. Also, and we responded through provision of medicines, and although there was no specific medicine dedicated to treating COVID, but there were COVID-19 kits and medicines that were thought to be providing good prognosis during the hospitalization. And also we managed to brought oxygen supplies throughout the country, and improved the prognosis of the COVID-19. Also not forgetting the PPEs, personal protective, and also providing trainings for the infection prevention control and supplies. At the same time, the provision of interagency emergency kit. Also, now that I can say sometimes, despite COVID-19 disrupting the country, somehow there was also blessings in the sky, and this was that we were able to the medicinal oxygen, and we had a supply. We had the country bought through World Bank projects and oxygen plants, and this also supported in childhood pneumonia, and there was also support and also reduction of the mortality rate of the children with who were dying from pneumonia. Also, we had thermal scanners equipped at all points of entry, including the international airport. And next slide. And well, here, and you can see our team in the technical laboratories being trained. The top picture to the left, they are learning how to do the genomic sequencing of the COVID-19 variants. And also, the other one on the right side is technical staff. They're testing COVID-19 sample through the PCR. And also here below, this is at the federal member states, whereby Somalia is a federal member state, whereby we have 7 other federal member states that where the federal member states that we support them, but they are somehow independent of running their health responses at the federal states level. Also, we can see an offloading of medicine kits. This is one way of also the response. And next slide. Well, this is when actually the oxygen plants that were brought to the country, and this oxygen supply did not only supported in fighting against the COVID-19, but also reduction of the pneumonia cases. And these oxygen were bought from the partners and also private companies really contributed to the country at this particular moment and when the time was in need. And next slide. Well, and the main topic of the day was the climate projections and for Somalia, and the threefold increase in the climatical events, as you have seen my first right. There has been 3 major droughts since 2010, and locust swarms. Air temperature over Somalia is very likely to rise and by 1.4 to 3.4 degrees Celsius by 2080. The sea level at the Somalia coast is also projected to rise with high salinity between 36 and 42 centimeters by 2080. Per capita water availability for Somalia can be expected to decline by half by 2080. 4 consecutive rainfalls now have failed, and we are also now actually, hopefully not, but the 7th one is missing also. And we have over 1.6 million internally displaced population who need of humanitarian aid and continue to experience physical and mental issues as a result of the climatical change. And next slide. Well, and some of the projections projections for climatical shocks is more frequent weather events, increased wetter years, and floods, and also dry years. Now we're in the dry season and the droughts, and once the rainfalls comes, there is a lack of preparedness to preserve the rainwater, and mostly also to result into event. And resurgence of resurgence of disease and climatic attributed death and disability, also agricultural crop loss and internal displacement, also extreme hunger. All this is climatical security implications. And next slide. Under the SCDG of goals in Somalia is currently off track, and no poverty. 69% of the people live below the poverty line, and these are the SDG goals that there will be no poverty, but then also we can see that still we are way far and off track. Also, zero hunger, 79% of the population experience either moderate or severe food insecurity. And also the other goal was good health and well-being. Universal health services coverage is 27 out of 100. So we have still a long way to go here. Clean water and sanitation, 32% of the people using safely managed sanitation services, and 52% of the people using safely managed drinking water. And climate action, and the people are still also facing climatical and shocks. So all these events and the goals are off track and way below the accepted areas. And next slide. So just in this one, I would like to shows more of health system suffers if food system are not working for health. This is just to showing how the nutrition, food insecurity, and decreased or delay access to healthcare, how the food security and the healthcare are interlinked. And as we can see, food security and livelihood assets will result to decreased delay health access, increase in financial barriers to healthcare, and deteriorating health-seeking behaviors. Also, this increased health risk, reduced, increased conflict over resources, increased of gender-based violence and domestic and sexual violence will relate to morbidity. And also on the other side, we see inadequate diets will lead to malnutrition, and morbidity will all lead to mortality. And increased access to health services will be is the solution to do that. And no, food security is more advanced needed today than before, and all we know that malnutrition and all this linked to food insecurity. And next slide. The impact of drought in the country is 4 to 5-fold increase in childhood diseases like measles, cholera, and pneumonia. And these are actually diseases that are history to most of the developed countries, but here we have them endemic and keep on repetitively. 2-fold increase in severe acute malnutrition, extreme hunger, water shortage, severe food insecurity, and malnutrition, slowing down the economical growth of Somalia by 0.4%. And below optimal performance of productivity sectors, and exponential increase of conflicts and internal displacement, leading to people living in extreme poverty. And this is in 7 in every 10 Somalis might live below and $2 a day. And also increase to vulnerability for marginalized women, youth with informal roles within the food system. And next slide. And food security and nutrition essential ingredients to build and back better. And I think the best approach will be to intensify multi-sectoral efforts to combat the effect of climate change and support of scaling up social protection programs, building resilient health systems, and making the health system and nutrition as an integral part of the inclusivity of the recovery. Also promoting a durable solution that will benefit the population in displacement, and also strengthening their resilience by avoiding negative impacts on the critical livelihoods and access to land and natural resources. So we also need to advocate for inclusion of women and youth as in the sector. Also, this will stimulate the market and provide livelihoods opportunities for the rural people. And next. And thank you. And before I conclude I would like to share or just wanted to share this report that is it? Can you see it?
Yes.
And let me. So this is an insight for the.
Actually, it just disappeared.
It disappeared?
Yes.
Go ahead and share it again.
Okay, let me share it again now.
Thank you. Yes.
Yes, this is a fresh report that is not yet published, and it was done together with London School of Hygiene and all the UN agencies involved, WHO and FSNU. And this is insight for examining the mortality rate, and this is also linked to the theme today. And you can see the estimates in the 2022 and droughts crisis caused 43,000 access deaths, with half of these occurring in children younger than 5 years. And this figure is higher than the year 2017 and 2018 combined. So we can see from this report that the mortality estimates the rates of accrued death between 2015 to 2022, and we can see how the trends are going up, and also estimated deaths by person, the rates on 10,000 days by district in Somalia 22. You can see all this, and is the greatest.
Dr. Ahmed, thank you so much. Is it possible for you to share this report? We have to move on to the next speaker now, but there's been a request if possibly people can take a look at this report. If you could drop a link in the chat. Thank you so much.
Yes. Okay, thank you very much. That's it from my side.
Thank you so much.
Yes, thank you so much, Dr. Ahmed. That was a fantastic overview, and for me personally, very exciting to see the link and importance of food security and nutrition in your presentation. And actually, we have a slight change in order for just our next presentation is actually going to be Dr. Shaban, who I know this is a slight change. I just want to make certain that that we're able to tell Dr. Camila Rodriguez that she will actually be going third, because we are fortunate to have Dr. Shaban. Just 2 seconds, sorry. I am very sorry. I had a slight change in the order, so just give me 2 seconds.
So Dr. Shaban, why don't you get started?
Oh,
We're so
I'm sorry.
delighted.
Sorry, just that my screen had frozen. I would just like to be able to introduce Dr. Shaban, but I apologize that my screen had frozen. So I'm thrilled to be able to introduce Dr. Shaban Senyange from the Uganda Public Health Fellowship Program. He's a field epidemiologist and actually comes to us with the very pertinent perspective of One Health. And so he actually has a master's degree in occupational health and safety and management, and he's an award-winning wildlife health and conservation media specialist. He has previously paired his dedication to wildlife conservation and passion to media with creating a television program called Ecozone, which seeks to create awareness about wildlife conservation through travel. And he's worked in several organizations relating to environmental conservation and biodiversity. And so he is actually the voice of a program called The Sides of a Horn, which is the first film to tell the story of Africa's poaching war from both sides of the fence. So he is currently in the Department of Integrated Epidemiology, Surveillance, and Public Health Emergencies in Uganda. And he supports surveillance, preparedness, detection, and response to priority diseases in Uganda. And in addition, offers support to their IHR capacity, including disease reporting mechanisms, and particularly in the timely investigation of disease outbreaks. So I'm very excited to hear from his One Health approach. And Dr. Senyange, I apologize for the delay, and I hand the microphone over to you, and welcome.
Thank you so much. Can everybody hear me? Am I audible?
Yes.
Awesome. Is it you who's going to help me navigate the slides?
No,
Yes, you can just see the next slide.
Okay. All right, thanks. Good afternoon, everyone. My name is Shaban Senyange from the Uganda National Institute of Public Health, and I'm very excited to be here. Apologies if I sound a bit, I have a bit of a cold, so if I sound like I'm speaking from my nose, apologies. I'm also just settled back because I've been engaging young African leaders at a symposium in South Africa, by looking at issues around climate change and health related issues, and merging that with community development. So I'm very excited to jump right into this discussion today, talking about issues on a much broader spectrum, obviously cutting across different continents. And before we get started, I always like, it's on Zoom, otherwise it would have been exciting to do this in person. I just want to invite us all to take a moment. Say if you were asked to paint a picture of what, say, climate change and forced migration looks like in our very own communities and in our very own surrounding. If you were asked to paint a picture, what would that picture look like? So I'm going to invite us all to just take a quick moment, paint those pictures, and we can start from there. I was trying not to do a countdown, but I'm hoping everyone has had a visual representation of what that looks like in their very own communities. And I always like to start off with that, because then a lot of times when we are asked to have a picture of what climate change looks like, we tend to withdraw from what the realities of that is, And one of the quotations, obviously, from the former US president, he said, we are the first generation to feel the sting of the impacts of climate change, and yet we are the last generation that can do something about it. And that, for me, really paints a very thought-provoking image of what the realities of climate change is, and also what needs to be done on that front to be able to move the continent forward. As the introduction said, I come from a completely different background, looking at the human, wildlife, and animal interface, and also incorporating aspects of climate change into public health. Next slide, please. So yeah, this really, just a reminder, everyone, what we are looking at. The fact that extreme weather in the form of global warming has far-reaching consequences, including food insecurity and the emergence of infectious diseases. And all these are really driven by environmental degradation. And in a way, this is really to remind us that nature will always strike back. And like Robert Greene quoted, in nature, these are consequences and not punishments or rewards. And, we'll see this a bit ahead, but climate change affects the social and environmental determinants of health, whether that be clean air, safe drinking water, sufficient food, and secure shelter, as the previous presenter once said. And when we are taking into aspects of whether we are doing messaging to educate people or sensitize communities about the impacts of climate change, it is really difficult to get people to care about these issues if they're not guaranteed their next meal, if they're worried about sending their kids to school. It's hard for them to care about these things, or even about species extinction, if all they care about or all they're worried about is really basic human survival. And so if we do not incorporate all of these aspects into our emergency response strategies, then we are not going to be helping the populations, especially when it comes to creating awareness and getting everybody to know that they actually have a shared responsibility in ensuring that we revert the effects of climate change. Next slide, please. It's like a lot has been said about, the global temperatures rising to 1.5 degrees Celsius and what that could do and how much of that is considered safe. And there's already a lot of conversations that are happening to avert, the catastrophic health impacts and prevent millions of climate change related deaths. And a lot of conversations are now happening into how does the developed and developing world really come together to be able to avert the effect of what could happen if the rise in temperature really hits to that level. And this is really pertinent with the kind of work that I do at the moment with the Institute as well, my own individual work. And this is why the TV show was created as well, to be able to create platforms for these conversations to happen. Next slide, please. I mean, this image does show an overview of climate-sensitive health risks, the exposure pathways, and vulnerable factors. And if you look at it quite closely, the climate change impacts really affects both health indirectly and directly, and is strongly mediated by environmental, social, and public health determinants. And I mean, climate change is already impacting health in a myriad of ways, including leading to death and illnesses from increasingly frequent extreme weather events, if you're talking heat waves, if you're talking storms, floods, and the disruption of food systems, increasing of zoonoses, which I'll talk about later, whether that be water or foodborne diseases, mental health issues as well. But climate change is really undermining many of the social determinants of good health, say livelihoods, equality, and access to healthcare and social support structures. And this we've seen throughout pandemics, say like COVID-19, and the previous presenter really did a solid job at painting a picture of what that looked like in terms of the health structures that we have in place. And these climate-sensitive health risks are disproportionately felt by the most vulnerable and disadvantaged populations, if you're talking women, children, ethnic minorities, poor communities, migrants, and displaced persons, older people, and those who are already living with other health conditions. If we go on to the next slide, please.
Shaban, I just want to give you a little bit of a timing warning. We have 15 minutes left for your presentation.
Awesome. Yeah, so the vulnerability really, certain groups are more vulnerable than others to health impact of climate change due to social and economic factors, say like income and education, health access, and housing, and such factors can affect people's ability to prepare or cope with climate hazards. And say communities with weak infrastructure might be the least able to cope, especially if there's no assistance to prepare and respond, and as a result, this might disproportionately affect these populations that are affected by global warming, and these populations are less resistant to these effects. And one of the things that really stands out is the eastern part of Uganda that last year was affected by floods, and there's been a lot of issues throughout the year. If we trace it back to 2010 and last year as well, about 40,000 people were affected by floods last year, and 3,600 of those were displaced and forced to live in temporary shelters. And just this year alone, there was another flood in January, during which 26 people were killed. And that just really goes to show how much of this is actually happening and the impact that is being felt on the ground. If we could go on the next slide, please. So this is some of the impacts that we're talking about. We could talk about the direct impact, which could lead to fatalities, whether that be waterborne diseases, water availability and accessibility, vector-borne diseases, which I will tap into later, or foodborne diseases. In 2022, towards the end of last year, I was part of a team that responded to a cholera outbreak in one of the refugee settlements in southwestern Uganda. And one of the issues was you have an influx of refugees coming in, and there's very limited accessibility to water, but that coupled with constantly changing weather patterns, there was a period of like a week where there was constant downpours, and when you merge that with a community that is not working towards having proper hygiene practices, then the water sources that we were depending on for, doing house chores and cooking and all these other things were contaminated. And this was the common source of water from for that particular refugee settlement. And that ended up being our point of contamination. But living in that kind of setting makes it really difficult for people to have access to that. And that really just goes to show how the seasonal changes in patterns that we're experiencing right now is creating some of these constant environments for diseases to be able to thrive in these environments. If we could go on to the next slide, please. This was really highlighted before, like this is increasing diseases, especially if it's related to diet and food security, and this we've really witnessed in many rural communities in the country.
Were you able to get the
I know running a bit of time, I'm just going to skip a bit of these common diseases that we've witnessed and really just focus on the zoonotic interface that I think might add a brilliant discussion to the table. So if we could move to slide 10, please.
Please tell me which slide you'd like me to stop on, okay?
It's the one that has the tri-circle. This one. Yes. So obviously living in a country like Uganda that is gifted by nature, obviously. You also have one of the youngest populations in Uganda right now, within the ages of 25. And what that is doing is the population is growing at such an alarming rate, and this is putting a lot of pressure on resources. And what that is doing, it's creating more interface between humans and animals and wildlife. And this also includes like deforestation. So what is happening, and this was the same issue with COVID, after COVID-19, and what we learned. I read an article of scientists warning that the next pandemic is here if we do not change how we relate with animals. And this is one of my interest areas, looking at the intersection between human health, environmental health, and animal health. And what is happening right now is the pathogens have already existed in the wild and with animals for a very long time, and what they really need is an opportunity to find new hosts, and these constant human interactions are giving them the opportunity to do that. And so the One Health approach is really key in studying and designing solutions to climate change-related human health effects, because it recognizes that climate change affects animals too, and animals are an integral part of human health. And I came across this quote that says, "Our health is intrinsically linked to the health of our planet." And that really just goes to show. And so the One Health really emphasizes that we are all connected, and recognizing this and acting with understanding, then we can begin to find meaningful solutions. And the zoonotic disease interface is already a public health burden globally, but in Uganda specifically because of its location, its biodiversity, and its population. And the problem really is not the animals. It's us, These wild animals have always had the viruses cruising through their bodies. But because of agriculture intensification, deforestation, urbanization, it's bringing people closer to the animals and giving the viruses more of what they need, and which is opportunity. And we've already created disease of priority concern, and that's what we do with the Division of Integrated Epidemiology Surveillance. One of the diseases that I've really had a chance to work on a lot is anthrax. And we all, I don't know how many of us know anthrax, but it's a bacterial disease caused by Bacillus anthracis that lives in the soil. And it's three different forms. You have cutaneous, you have gastrointestinal and pulmonary, and cutaneous anthrax accounts for 95% of these cases. And the problem is most of these pastoral communities live at the peripherals with the national parks in Uganda. And we are talking about forced migration, but in my case, it's not just forced migration of the humans. Climate change is also affecting animal populations and how they migrate. And what's that doing is really creating conditions for new viruses to emerge, for bacteria to be, this changes in seasons are also changing disease epidemiology and how that plays out. Case in point, anthrax. In 2018, there was recurrent outbreaks in Zombo district, Arua district, Kwen district, and Chirhura. Just to give context, two of them are east and the other two are north, in the northern part of the country. And just in 2018 alone, there was 186 cases of human anthrax and 721 livestock deaths from anthrax. And there have been recurrent outbreaks, especially in the east, every single year. But what we are starting to witness now, there's 2 outbreaks of anthrax almost every single year. And that is attributed due to the changes in the weather patterns. When you have droughts, then the domestic animals will graze in the national parks. And what that does is that more continued interaction between the domestic animals and the wild animals, and them feeding closer to the ground, then they ingest the spores. And the thing about anthrax, once they feed, they go back to the kraals. Within 6 hours, the animals have died. And so the pastoralists do not know, there's no early warning signs with the cattle because you have sudden death. And what the communities do still, because they are poor communities, and when an animal has died, obviously their first response is not going to be to call a doctor, a veterinary doctor, to check out the animals. So the communities will normally slaughter the animals. And that's the only time really that people get infected, when they either eat meat from an animal that has died suddenly, or when they come into contact with parts, say like the skin and the meat. And that's been mostly the issue that has caused anthrax. And we've been able to witness anthrax not only in that community that was quite a hub of anthrax, but it's really starting to spread to different regions that ideally were not known to be anthrax districts, if I could say that, but because of the transport industry. And so we did a study in one of the districts that has been having recurrent outbreaks, called Kazo district, that was cut from Chirhura in southwestern Uganda. And we did a knowledge, attitudes, and practices study on communities from previously affected outbreaks to really find out what is the issue, what is the missing link, to understand if people knew of the dangers of eating meat from animals that have died suddenly and why they continue to do it. Vaccination of animals, if that's happening, how many animals were vaccinated, what kind of community outreach programs and sensitization campaigns were working, and what needed to be changed to explore if the One Health approach was effective. Because in Uganda, we have the surveillance system in the human population is really developed, and you get fast track information when that happens. It's not as developed in the animal sector. And so what we are currently working on is having that integrated approach so that there's real-time surveillance data that comes in to be able to track the animal deaths, and that way we can be able to predict outbreaks, say in the human population, if we know what's happening from the animal side. I'm happy to share the link of that study that we did. It was published in the quarterly bulletin of Uganda National Institute of Public Health Epidemiology Bulletin. So I'll be able to share the link of that, and people can just get a more in-depth knowledge of what that study looked at and what kind of things we considered, some of the methodology that we use, and an insight into what the problem is in terms of anthrax. If I could go to the last slide, please. You're looking at I always think like the human-wildlife interface is one of the most underrated sectors on the continent, and merging it with health and digital innovations and supporting livelihoods to make a more integrated approach will really make an interesting field to explore. And I'm not coming from a biased background because this is what I'm passionate about, but I do feel like with the current growth in populations and more pressure on natural resources and more interactions within humans and animals, that interface is going to become much more important. And unless we change how we interact with animals, and unless we continue to look at ways of integrating animal health and environmental health into public health interventions, then we're constantly going to be faced with this kind of problems. And if I think COVID was a blessing in disguise about showing what impact a disease from an animal origin could do to the world. And I think that really served as a ballgame for us to prepare and work on strengthening partnerships with different key stakeholders that are playing at the One Health field to be able to make those efforts even better. Yeah, and I think we are in a very good space to be able to make that happen. And it's going to take collaboration. So I'll end at that. Thank you, and I'm happy to have this discussion further, and I'll share resources that people might require to be able to delve deeper into this conversation. Thank you so much.
Thank you so much, Dr. Sanyange, and also for sharing this, really your perspective on the One Health approach with this very compelling example of anthrax and the pastoralists in Uganda. And so that's really very pertinent to our discussion today. And please do share the link. So I would now like to move to our next speaker, Dr. Camila Rodriguez Acevedo. Before I introduce her, we actually have a lesson in using the interpreter button. So I think actually, Caitlin, did you want to share a slide with us?
Yes, so our next presenter will be presenting in Portuguese, and so we have translation available. You should see a globe at the bottom of your screen, and if not, please click on the 3 dots that are next to the word more, and you should see an option for interpretation, and you will be able to hear the presentation being translated from Portuguese into English.
So I hope that if anyone has questions, please put them in the chat. And I will now move on to introducing our next speaker, who will be speaking in Portuguese. So those of us not fluent in Portuguese need to click on for the option of English. Dr. Camila Rodriguez Acevedo is specialized in public health. She is a trainee at the Brazilian Field Epidemiology Training Program, EPISUS, where she's been from 2021 until now. She has supported or conducted field investigations of COVID-19 in the context of hospital surveillance and with populations deprived of liberty, specifically in female penitentiaries. And in addition to acting in response to the hydrological disasters that occurred in Bahia in the year 2021 in Brazil. She has experience in the development of research in public health from the University of Brasilia in 2018 through 2020. And she also collaborated in the Workers' Health Laboratory in the Department of Collective Health at the same university in Brasilia. She is actually a nutritionist undergraduate from the University of Selma, and she's a specialist in public health from the Fiocruz School of Government, also in Brasilia, and in sanitary surveillance from the Institute of Pharmaceutical Studies, IFAR, in Brasilia. So it's my great pleasure to say bem-vinda to Camila, and I hand over the microphone and just encourage everyone to use the interpretation as needed. Camila.
Bom dia. Vocês me escutam direitinho?
Sim, Camila.
Ok?
Yes.
Yes.
Então, obrigada. É um prazer estar participando desse evento. Eu vou apresentar hoje um trabalho que a gente desenvolveu no âmbito do programa de treinamento aqui do Brasil, que foi uma resposta epidemiológica aos desastres hidrológicos, através de uma análise sindrômica de prováveis doenças na população desabrigada na Bahia, no ano de 2021. Então, pode passar o próximo slide, por favor. Eu trago como introdução para a gente contextualizar um pouquinho o tema, sobre o que a gente levou em consideração em relação aos desastres. Então, pode passar, por favor. As emergências em saúde pública, elas são situações que demandam um emprego urgente de medidas de prevenção, controle e contenção de risco, danos e agravos da saúde pública, nas seguintes situações. Então, uma emergência de saúde pública, ela pode ser surtos e epidemias, desastres e desassistência à população. Para o nosso trabalho de campo que eu vou apresentar para vocês, a gente focou, então, nos desastres. Pode passar, por favor. Pode passar mais uma vez. Pode. Então, os desastres, eles são eventos, né, que configuram situação de emergência ou estado de calamidade pública, que vão implicar em atuação direta na área de saúde pública. Eles podem ser subdivididos em naturais e tecnológicos, a gente vai focar nos desastres do tipo natural, e os desastres do tipo natural são subdivididos ainda em geológicos, hidrológicos, meteorológicos, climatológicos e biológicos, e no caso da resposta que a gente foi dar ao território, era um desastre do tipo hidrológico de inundações. Então, já fica aí na cabeça de vocês que o nosso trabalho ele foi desenvolvido no âmbito de um desastre de inundações. Pode passar. Então, os efeitos da inundação sobre a saúde humana, eles são diversos e perpassam o aumento da ocorrência de doenças infecciosas, como já foi falado em apresentações anteriores, isso já é bem trazido na literatura, esse aumento de ocorrência de doenças infecciosas, de surtos, o agravamento de doenças crônicas não transmissíveis, especialmente em pessoas que já são acometidas por esse tipo de doença, seja por descompensação, né, pela descontinuação do medicamento de uso contínuo, por exemplo, o aumento do risco de transmissão de doenças devido à aglomeração de pessoas. Então, como essas pessoas são deslocadas para abrigos, elas ficam mais aglomeradas e isso aumenta o risco de transmissão de doenças, além do surgimento de transtornos mentais. Então, pode passar, por favor. Os abrigos a gente considerou que seriam acomodações temporárias para pessoas deslocadas por desastres. Eles são não residenciais, então eles são estádios esportivos, escolas, igrejas, e tem graus variados de infraestrutura sanitária. Próximo. E o desabrigado, que é a nossa população, seria o desalojado ou pessoa cuja habitação foi afetada por dano ou ameaça de dano e que necessita de abrigo provido pelo sistema. Então, essa população desabrigada, né, que teve algum grau de infraestrutura nas suas casas, tiveram que sair desses locais e foram acomodadas nos abrigos que foram providos pelo sistema. Então, o nosso objetivo do trabalho, pode passar, por favor, ele foi, pode passar, descrever o perfil epidemiológico da população de desabrigados nos municípios do sul e extremo sul da Bahia, no período compreendido entre 23 de dezembro de 2021 e 12 de janeiro de 2022. E os objetivos específicos foram levantar os casos prováveis das principais doenças existentes em situações de inundação e propor recomendações. Próximo. Eu acho que tem algum microfone aberto. O desenho do nosso estudo foi um estudo do tipo descritivo, iria delinear, então, o perfil epidemiológico dos desabrigados. A temporalidade do nosso estudo foi de 23 de dezembro de 2021 a 12 de janeiro de 2022. E como local de estudo, nós tivemos o Núcleo Regional de Saúde Sul, na região de saúde de Ilhéus, Itabuna, Jequié e Valença, e o Núcleo Regional de Saúde Extremo Sul, na região de saúde de Teixeira de Freitas. Próximo. A população do nosso estudo foi, então, a população desabrigada nos municípios do Núcleo Regional de Saúde Sul e do Núcleo Regional de Saúde Extremo Sul, na Bahia, entre 23 de dezembro de 2021 e 12 de janeiro de 2022. Próximo, por favor. Como fonte de coleta de dados, nós fizemos a coleta de dados primários através de um questionário semi-estruturado aplicado com a população de desabrigados. Então, a nossa equipe de campo desenvolveu esse questionário semi-estruturado, que foi, então, aplicado com essa população. E ele tinha diferentes variáveis de interesse, como dados do desabrigado, informações clínicas e epidemiológicas pregressas, e informações sobre doenças, agravos e eventos à saúde, como vocês podem dar uma olhada no quadro que está apresentado. Então, a gente fazia o levantamento de diferentes informações através da aplicação do questionário. Próximo. Para a nossa análise de dados, então, a gente utilizou a abordagem sindrômica, uma análise sindrômica, que consiste na classificação de doenças e agravos de acordo com síndromes pré-estabelecidas, baseadas em sinais e sintomas. Eu vou mostrar para vocês um pouco do passo a passo do que a gente fez para conseguir levantar esses prováveis casos de doenças no território. Próximo, por favor. Então, primeiro a gente fez o levantamento das definições de caso que estavam presentes no Guia de Vigilância em Saúde do Brasil. Próximo. Posteriormente, a gente fez a criação de variáveis de análise no EpiInfo. Então, a gente, a partir das definições de casos que a gente tinha no Guia de Vigilância em Saúde, a gente criava variáveis de análise no EpiInfo. Próximo. Nós criamos 173 variáveis. Essas variáveis eram combinações de sinais e sintomas a partir das definições de caso que a gente tinha no Guia de Vigilância em Saúde. Próximo. Posteriormente, a gente ia, então, a esses abrigos, fazer o levantamento dos sinais e sintomas dos desabrigados, com o questionário semi-estruturado que eu apresentei para vocês. Tem uma imagem dele aqui no canto direito. Então, a gente fazia esse levantamento dos sinais e sintomas dessa população. Próximo. E aí, a gente conseguia fazer a identificação de casos prováveis das principais doenças relacionadas às inundações. Então, a gente elencou a doença diarreica aguda, síndrome gripal, Covid-19, dengue, chikungunya, zika, leptospirose e o sofrimento mental. Próximo, por favor. Utilizamos para análise o EpiInfo e o Microsoft Excel. Em relação aos aspectos éticos, a gente tem a Lei 8.080, de setembro de 1990. Essa era uma ação de vigilância em saúde, onde foi respeitados os aspectos éticos e a gente pediu o consentimento verbal da pessoa para que ela respondesse o nosso questionário. Já partindo, então, para os resultados, pode passar, por favor. Eu trago, então, o fluxograma das entrevistas que foram realizadas nos abrigos, na região sul e extremo sul da Bahia. A gente conseguiu realizar 667 entrevistas com essa população, sendo 46 na base Gandu, 381 na base de Itabuna, 121 na base de Ilhéus, 110 na base de Jequié e 9 na base de Teixeira de Freitas. Próximo. Em relação ao perfil sociodemográfico destes desabrigados, 59,8% eram do sexo feminino, a mediana de idade era de 24 anos e o intervalo, o primeiro quartil e o terceiro quartil era de 13 a 41 anos. Dessa população de desabrigados, 86,8% tinham familiares nos abrigos. Então, como foi uma situação de inundação, que a gente teve perda das moradias, muitas famílias inteiras foram deslocadas para esses locais. E 60,1% receberam orientações sobre saúde nos abrigos. Próximo. Como resultados, então, da nossa análise sindrômica, onde a gente conseguiu levantar os casos prováveis de doenças a partir dessa análise. Em primeiro lugar, a gente teve, então, casos prováveis de síndrome gripal, com 54,9%, seguido de sofrimento mental, com 39,3%, dengue, 22,3%, e Covid, 12,7%. Esses foram os prováveis casos de doença que a gente conseguiu fazer o levantamento a partir da nossa análise sindrômica. Então, já partindo para as conclusões do nosso estudo, Pode passar, por favor. A maior parte dos desabrigados, eles eram do sexo feminino e tinha uma mediana de idade de 24 anos. A síndrome gripal, ela foi a provável patologia com maior frequência, seguida de sofrimento mental e dengue. No entanto, a existência de Covid-19, doença diarreica aguda, leptospirose, chikungunya e zika, elas causavam preocupação e a gente deveriam ser avaliadas. Então, estudos apontam o aumento na incidência de doenças potencialmente epidêmicas nos períodos após as enchentes e inundações, com o aumento de doenças transmissíveis. Além, dessas doenças que envolvem agentes biológicos, a literatura também aponta para os impactos sobre a saúde mental e emocional das populações expostas às enchentes. Pode passar, por favor. E aí, no decorrer do nosso trabalho de campo, a partir do levantamento que a gente ia fazendo, eram dadas recomendações ao território para que eles pudessem dar resposta, a essas doenças que a gente ia elencando. Então, como recomendações, realizar o cadastramento de todas as pessoas e famílias acolhidas nos abrigos, especialmente com informações sobre situação de saúde, presença de sintomas, orientar os desabrigados quanto às medidas de contenção e disseminação de vírus, como o uso de máscaras, higienização das mãos, comunicar casos suspeitos de Covid-19 para as autoridades de saúde, para a realização de testagem, manter equipes volantes de saúde prestando assistência aos abrigos, manter a assistência farmacêutica para os desabrigados, especialmente aqueles com necessidade de medicamento de uso contínuo, como hipertensos, diabéticos e pessoas com alteração do estado de saúde mental, além de promover assistência de saúde mental aos desabrigados, com avaliação psicológica e acompanhamento do estado de saúde mental. Essas foram algumas recomendações que foram dadas no território, mas outras também iam sendo orientadas no decorrer da nossa resposta ao desastre. Então, já finalizando, pode passar, por favor, eu trago fotos do nosso trabalho de campo. Ele foi um trabalho feito a muitas mãos, então a gente só conseguiu chegar àquele quantitativo de pessoas desabrigadas, que estavam espalhadas em vários abrigos na cidade e em outros municípios, devido a várias pessoas que participaram dessa resposta. Então, aproveito para agradecer todo mundo que participou desse trabalho, que foi muito importante. É isso, muito obrigada. Fico à disposição para responder qualquer tipo de questionamento sobre o nosso trabalho. Obrigada.
Thank you very much, Camila. Obrigada. If possible, could the three panelists put on their cameras, if it's possible? I'd just like to open up the Q&A session. And so I would like to ask all three of you, Dr. Samyange, Dr. Rodriguez, and I'm looking for our first panelist. Are you still present? And Dr. Ahmed, I'd like to request if each of you could, I guess, perhaps Dr. Samyange, and then Dr. Rodriguez, and I'm still looking on my screen for our first panelist, so I hope you are still with us. So I would like to ask each of you if you could please, actually, I do see that here, so we'll go in order. If each of you could tell us, really for the audience, what do you consider are the most pressing health challenges related to climate change and forced migration? I think each of you touched on it in different ways, but if you could specifically tell us what were the challenges that you feel relate to this, that field epidemiologists really need to consider and need to respond, is what are the most pressing health challenges. So if I could start, I don't know if either of you, any of you wants to start, or otherwise we could go in order of presentation. Okay. Well, then I will start with Dr. Ahmed. Dr. Ahmed, would you be able to tell us what you consider is the most pressing health challenge related to climate change and forced migration from your perspective, and what field epidemiologists might need to do to respond? I'm not certain if Dr. Ahmed has been able to hear the question. So Dr. Sanyangi, would you be able to answer the same? I know you gave us your perspective, including the One Health, but I'm wondering if you could specifically tell us, related to forced migration and climate change, what aspects would be the most pressing that field epidemiologists would need to be considering in their responses? Okay, I think maybe we don't have Dr. Sanyangi right now. So Dr. Camila, could you tell us, I know you just gave us one compelling example, but from your perspective, what do you think would be the most pressing health challenges related to climate change and forced migration that field epidemiologists would need to consider and respond to? And I know you just gave us some examples from your Bahia work, but I'm wondering if you could abstract also from perhaps from other work that you've done, what you consider are the most pressing health challenges related to forced migration due to climate change.
Bom, obrigada pelo questionamento. Eu acredito que o nosso principal desafio é se organizar para conseguir enfrentar esse desafio, né? Porque quando a emergência chega, o desastre chega, a gente já tem que dar uma resposta muito rápida para tudo aquilo que está acontecendo, e acontecem muitas coisas ao mesmo tempo: óbitos, agravamento de doenças crônicas, surtos de doenças infecciosas. Então, é tudo muito emergencial e tudo muito rápido. Então, acho que o nosso principal desafio é conseguir preparar respostas para o território antecipadamente, para que a gente consiga responder da melhor forma possível todo esse arsenal de doenças, de questões que aparecem numa situação de migração forçada. A gente tem os agravos também, as violências, os acidentes, que também são frequentes em situações como essa. Então, acho que o nosso principal desafio é se preparar anteriormente para conseguir dar uma resposta oportuna para essa população no território. Eu acho que é um desafio muito grande.
And thank you, Dr. Rodriguez, and that actually connects to one of the questions that we had received, which was specifically asking what actions countries should consider implementing to address forced migration. And it sounds in some ways like you're saying one should anticipate that forced migration is going to be happening. And so at least in the case of Brazil, are there any actions that are being implemented to address the forced migration? You're in a setting where you're getting both internal and international migration. So just wondering if you could tell us a bit about policies that Brazil might be implementing specifically to prepare or address, since you're having it.
Aqui no Brasil, a gente tem planos de contingência, né, que são organizados para as inundações, para a emergência de saúde pública, para esses desastres que a gente vem enfrentando. Alguns já são comuns no Brasil, as inundações, elas frequentemente acontecem no nosso território a cada ano, então a gente tem planos de contingência para isso. E eu acho que os programas de treinamento, né, no nosso caso o EPSUS, tanto o avançado como os outros níveis, o intermediário e o fundamental que a gente tem aqui no nosso país, eles são muito importantes. Então, as ações que são feitas no território, elas acabam subsidiando ações posteriores. Então, esse próprio trabalho que eu apresentei aqui no âmbito do avançado, a gente teve algumas ações posteriores de desenvolvimento de materiais, de questões de saúde mental que foram realizadas no território. Então, o meu conhecimento são nesses planos de contingência que a gente tem no território e a própria ação mesmo do programa de treinamento em epidemiologia de campo, que é super importante, né, para essa resposta que a gente está nos desastres, nessas situações.
Thank you, Camila. I see that Dr. Sanyangi is back with us, but I will also give the microphone back to Dr. Sorensen. But I don't know if Dr. Sanyangi, if you wanted to comment on on the prior question, which was from your perspective on what you felt was the most pressing health challenge related to climate change and forced migration, and what field epidemiologists might need to do to respond.
Thank you so much. I think for me, the biggest challenge right now, and looking at it from a Ugandan context, is with forced migration. I'm trying not to get very political here. It's just when people are displaced and they're put into temporary accommodation, there isn't a lot of space, you know, and the issue is, one, how long are we keeping them there? But then second, what is the state of those temporary shelters, right? And we've gone through this phase, especially in Uganda. There was a new district that was created back in 2019, and the TB, incidence rate started going up, and we traced it back. There was flooding in one of the districts, and so you have people all getting into very, very small shelters, and you have big families. At average, a family can have about 5 or more members. So imagine even more than that in one place. So you have all this number of people in one packed condition, right? And then if you have young people and there's not enough access to food care, all these are risk factors that can increase the prevalence of TB. So I think it's really hard to look at just the climate change aspect from just one lens, right? So when you're looking at, say, if there's an outbreak and field epidemiologists are responding, it's really important to look at all these facets of climate related illnesses and not look at it from a health perspective, but ideally, how are you tapping into issues of food security? How are you tapping into issues of proper hygiene mechanisms? Because you could be addressing one issue now, you go back to write a report or something, and then another issue is going to rise. And this is why looking at it from really an integrated approach of looking at that lens. And this is why when we work with the local leaders, we work with the community educators, we work with the local leadership, so that then those people are also our champions when we leave and we tell them what the issue is. They keep on advocating for change at that front, but they're also able to provide data of anything that has changed beyond what we collect the data from, because data can also be very subjective. And so when you have people on the ground that constantly feed you with data of what's happening on the ground, it really helps you change the approach of how you're approaching that issue, but also ensuring that you really capture that issue from those different aspects. But I think for me is how we respond to one emergency and capture aspects of any other potential arising, because you don't want to leave the field after investigating or responding to one outbreak, only to go back and then a week later come back to address to another challenge in the same community.
Thank you so much, Dr. Sinyange, and thank you to all of our speakers and to our moderator. We really appreciate you being here today, Dr. Orjuela. This has been a wonderful session. We have so much expertise here in this Zoom session. I mean, it's incredible, all around the world that we're able to sort of tune in and really focus in on these issues related to frontline field epidemiologists and the ongoing climate crisis. So we have a seminar that is planned for every month. Next month, we will be focusing in on climate change and Indigenous health. If you have any case studies from your region, we would love to hear from you and learn about them and see if we could perhaps focus on your case study for our next monthly webinar. We will drop a link to our contact in the chat. So again, please feel free to reach out to us if you have any cases on Indigenous health. That will be the theme of our April monthly webinar. The following month in May, we will be focusing on non-communicable diseases and climate change. So again, if you have any cases related to that, we'd love to hear from you so we can focus in on your work. With that, another huge thanks to our speakers, to our moderator. This has been a tremendous learning opportunity, I think, for all of us, and we really look forward to seeing you all next week. Thank you, Caitlin. We do have Caitlin's email in the chat right now, so please feel free to reach out to us if you have any cases on Indigenous health or non-communicable diseases, or if you have any ideas for future topics you'd like to see us cover in this monthly webinar series. So with that, everybody have a wonderful day, and we look forward to seeing you soon. Take care.